Welcome to Chapter 3 of NUR 202. This is Assessment and Health Promotion. You have 6 objectives for this chapter. Identify the structures and functions of the female reproductive system. Describe the menstrual cycle in relation to hormonal, ovarian, and endometrial responses. Identify the phases of the sexual response cycle. Identify facilitators and barriers for women to access care in the healthcare system. Describe the need for health promotion across the woman's lifespan. And outline health screening schedules for women across the lifespan. The external structures of the female reproductive system include the mons pubis, labia majora, and labia minora, the clitoris or clitoris, vestibular glands, vaginal vestibule, the vaginal orifice, and the urethral opening. Collectively, these are all considered to be what's called the vulva, V-U-L-V-A. You can see page 32 for description and purpose of each of the external genital organs that are on this list. And there is the picture of the vulva or external genital organs of the female. Next, we have the internal structures: the vagina, the uterus, the cervix, fallopian tubes, and the ovaries. How would you describe the vagina? The book describes the vagina as a fibromuscular, collapsible, tubular structure that lies between the bladder and rectum and extends from the vulva upward to the uterus internally. The vaginal opening is between the urethral opening and the rectum. It leads to the cervical opening, which leads into the uterus. The vagina varies in size and shape. It has roux folds, which give it the ability to stretch and retract like an accordion. The uterus is divided into 2 major parts: an upper triangular portion called the corpus, and the lower cylindric portion called the cervix. The fundus, which you'll hear a lot about in this class, is the dome-shaped top of the uterus and is the site at which the uterine tubes enter into the uterus. The uterus serves as reception, implantation, retention, and nutrition of the fertilized ovum, and later the fetus during pregnancy, and then for expulsion of the fetus during childbirth. The uterus is responsible for your cyclic menstruation. Most people think it has to do with hormones, but it is actually the uterus that is responsible for that. The cervix is made up of mostly fibrous connective tissue and elastic tissue, making it possible for the cervix to stretch during the vaginal childbirth. A cervix can be long or short, and some believe it has to do with the height of the woman. Theory has it that shorter women have a shorter cervix, which means they will have a shorter labor. I don't know how true that is, but maybe you can tell me. Fallopian or uterine tubes attached to the uterine fundus. They are 8 to 14 approximately centimeters long, and the end near the ovary have finger-like projections called fimbriae that undulate to pull in the ovum when it's ejected from the ovary. Most women have 2 ovaries, and these are almond-shaped organs located on each side of the uterus, below and behind the uterine tubes. The main functions of the ovaries are for ovulation and hormone production. Ovulation is the release of a mature ovum from the ovary at intervals usually monthly, and estrogen, progesterone, and androgen are the steroid hormones produced by the ovaries. This is a picture of your internal female reproductive organs. This is a picture or schematic arrangement of directions of muscle fibers that are attaching to the uterus. Note the uterine muscle fibers are continuous with supportive ligaments in the uterus. As we grow older, gravity is not kind to us, and the more children we have, the more stretched out these ligaments become, and this can lead in older age to a prolapse of the uterus. The bony pelvis serves three purposes: for protection of pelvic structures, accommodation of growing fetus during pregnancy, and anchorage of the pelvic support structures. This picture is in your books on page 35, and on the left you have the adult female bony pelvis anterior view, and on the right it shows an external view of inanimate bones that are fused. This picture is important, especially the upper picture, because it shows you the false pelvis and the true pelvis. The true pelvis being the ischial spines portion, where it is the narrowest part of the pelvic inlet. The true pelvis is the narrowest portion, which means it's very important, and we call that zero station when the baby is descending. Zero station means the baby's head is engaged, and if the baby's head is too big to get through the true pelvis, then an emergency C-section would have to be done. But with ultrasounds, they usually know through measurements that the baby is small enough to get through the vaginal canal. The breast structure, they're paired mammary glands located between the second and sixth ribs. About 2/3 of the breast overlies the pectoralis muscle between the sternum and the mid-axillary line, with an extension up to the tail of Spence, which is a point that goes right up into the middle of your armpit or axillary area. The acini are lined with epithelial cells that secrete colostrum and breast milk. And the colostrum is very important to the baby in the first few days of life. It's rich in antibodies from the mother and helps them get a good start. This is a picture of the anatomy of the breast. Understand where the milk ducts are located and where the foremilk and hindmilk come from, which you will learn in chapter 24. If you want to look at page 611 in your books, you can see that. The hind milk is the milk that's rich in the fats, and it's stored more to the upper portion of the breast and to the axillary area. So if you see a woman pressing on her breast to bring the milk down, almost like she's milking her breast, it's to get that fat out of there so that the baby gets the benefit of that while they're breastfeeding. The breast function to serve for lactation, to provide breast milk for a newborn, and they are also considered organs of sexual arousal. Physiologic alterations in breast size reach minimal level about 5 to 7 days after menstruation stops, and this is the best time for a breast self-examination to be carried out during that phase of the menstrual cycle. Nipple stimulation can cause orgasm, and therefore it causes uterine contractions. So at the end of your pregnancy, if you have not gone into labor by your due date or past, they may use nipple stimulation and tell you to go home and have sex so you can have an orgasm, which causes uterine contractions, and maybe that'll jumpstart your contractions. It's worth a try. Menarche is the very first period that you will ever have. Puberty usually begins between ages 10 to 12 and lasts for several years. The menstrual cycle has different portions. Different types of menstrual cycle may be important. The one I like to talk about, we'll talk about on the next slide. But menstruation is the periodic uterine bleeding that begins approximately 14 days after ovulation. This picture depicts at the bottom of the picture the endometrial cycle, and that's the one I want to point out. On page 37, you can see a bigger picture of this. Menstrual cycle, pay particular attention to the endometrial cycle. Note the proliferative phase is the one where the lining is rebuilding back up after menstruation is over. And the secretory phase has the appearance of velvet. It's a smooth, velvety surface enriched with blood and nutrients in case an egg comes along that wants to implant so we can grow a baby. The ischemic phase is the breaking down and shedding of the lining or getting ready to shed the lining if no egg is implanted, and then you have another menstrual cycle. Prostaglandins are oxygenated fatty acids classified as hormones. Now, prostaglandins are produced in most organs in the body, and they serve to affect smooth muscle contractility and modulation of hormonal activity. They may play a key role in infertility and also in the triggering the start of labor. So prostaglandins are very important. Climacteric is the transitional phase during which ovarian function and hormone production decline. Spans the years from onset of premenopausal ovarian decline to postmenopausal time, when your symptoms stop. And menopause refers to the last menstrual period you will have. Dated with certainty 1 year after menstruation ceases. The average age is 51.4 years old, and the ages range actually from 35 to 60 years old. You can go into menopause. If you have a grandmother or mother or sister, close family member that you can talk to about how their menopause went, if they went through a natural menopause, it may give you an idea what kind of menopause you will go through if you go through a natural one. Sexual response, females and males achieve physical maturity at approximately age 17, and that individual development varies. First outward appearance of puberty may appear at a much earlier age. Women and men are more alike than different in the physiologic responses they have to sexual excitement and orgasm. Sexual stimulation results in an increase in circulation to the circumvaginal blood vessels. Venous congestion is localized primarily in the genitals and to a lesser degree in the breast and other parts of the body. Arousal is characterized by myotonia, resulting in voluntary and involuntary rhythmic contractions. Sexual response cycle is divided into 4 phases: excitement, plateau, orgasmic, and resolution. Time, intensity, and duration for cyclic completion vary for individuals and situations, and certainly depending on who your partner is. Some women may have multiple orgasms. Financial issues, cultural issues, and gender issues are all barriers to entering the healthcare system. Many of these issues vary from state to state and depend on how funds are distributed from local and state government agencies. If you look in your chapter on pages 39 to 40, you can see more about these barriers. Caring for the woman across the lifespan, we start with disease prevention and adolescence. Teenage pregnancies will always be considered high risk. Most of them, especially if they're under 16 years of age, cannot support themselves, and their eating habits can be very poor, like fast food all the time, which leads to nutritional problems, and especially iron-poor anemia. Young to middle adult females, age 20 to 40, have the need for contraception, so they're more apt to see a gynecologist than younger females. Either way, at any age, we must screen for alcohol consumption, smoking, and doing drugs, and do our anticipatory guidance as to teaching them what can have an effect on an unborn child. And after 35 years of age is considered also high risk, and a lot more women, for some reason, have decided that it's a good thing to wait till they're older to have their first child. Preconception counseling helps guide couples to prevent unwanted pregnancies. Activities that promote healthy mothers and babies must be initiated before the period of 17 to 56 days after fertilization. By the end of the 8th week after conception, and certainly by the end of the first trimester, any major structural anomalies in the fetus are already present. See your book, page 42, box 3.2 and box 3.3. Infertility may be caused by many things. It may be the man or it may be the woman. Previous illness, sexually transmitted disease that left scar tissue in the fallopian tubes, low sperm counts, congenital anomalies in one of the partners that maybe they didn't even know they had. Certain prescription drugs and many other things may lead to infertility. Seek help from a specialist to find ways to correct it. There are many ways they have now to correct infertility. Menstrual problems will be discussed in Chapter 4. In perimenopause, many women seek help for irregular bleeding and hot flashes. Fertility is greatly reduced during this time, but pregnancy is still possible. Some women even plan their pregnancies, like we said, for after age 35. Identification of risk factors. Social, cultural, and genetic. Chapter 11 will discuss these things in more detail, but remember that there is no safe amount of alcohol use in pregnancy. I don't care what you saw on TV or what somebody told you, there is no safe amount of alcohol to be used in pregnancy. Infants go through terrible withdrawals, and they don't deserve that from all the cigarette smoking, marijuana, cocaine, opiates, methamphetamines, methadone, and caffeine that we subject them to. So if you're of age to get pregnant, or you're trying to get pregnant, or you are pregnant, and you're doing any of those things, please do yourself and your baby a favor and stop. Nutritional problems. Nutritional deficiencies, obesity, eating disorders, and lack of exercise. We know that good nutrition is essential for optimal health, whether you're pregnant or not. On page 45 in your books, if you look at box 3.5 and 3.6, especially pay attention, please, to the ideal body mass index, or BMI, that we all should be adhering to. Obesity has increased dramatically in the past 20 years in the United States. With obesity come other problems like high blood pressure, diabetes, and immobility, just to name a few. Exercise contributes to stress reduction and weight maintenance, so this is also very important. Anorexia is a serious eating disorder that can cause many physical and metabolic disorders if not corrected. With this disorder often comes depression, and many times a woman who gets pregnant cannot carry the pregnancy to term because of the issues associated with anorexia. Bulimia and anorexia should be screened for in the primary care setting, and box 3.6 is a screening tool you may see used. Exercise also contributes to stress reduction and weight maintenance. Women report that engaging in regular exercise improves their body image and self-esteem and acts as a mood enhancer. However, strenuous exercise can lead to hormone imbalances, resulting in amenorrhea and its consequences. The best exercise that a woman can do while she's pregnant is stretching, like taking a yoga class. Every woman should learn how to do Kegel exercises and do it every day for the rest of your life. This exercise strengthens the muscles that support the pelvic floor. See the guidelines box on page 46. This picture depicts some women at the gym. It looks like a very small gym on the stationary bicycles. We're going to talk about stress. Stress, we know a certain amount of stress is necessary for us to respond and function properly on a day-to-day basis. We must learn, though, how to de-stress in our own little worlds, especially when you're taking on the new role as a mother. See box 3.7 on page 47 for some questions that you may ascertain the stress level that you and your patient might be at. Depression and anxiety may lead to heart disease and suicide. So if the patient becomes pregnant and is on certain medications for these disorders, it's important to ascertain this information because the drugs may not be compatible with the pregnancy. Pollutants such as tobacco smoke, carbon monoxide, smog, cleaning solvents, pesticides, chemical additives, and poor food preparation are things that a pregnant woman may be exposed to in her everyday routine. If these are work-related, though, she may need to quit her job or take some time off to keep from exposing her fetus. Sexually transmitted diseases can also endanger the fetus. If a woman tests positive for an STI while pregnant, she should be treated, and all of her partners should be treated, and then she should be retested before delivery to make sure that she is still negative. We will see slides in a different chapter on what can happen to an infant born with an STI. Certain medical conditions present during pregnancy can have a deleterious effect on the fetus. Some forms of diabetes, urinary tract disorders, thyroid disease, hypertensive disorders of pregnancy, cardiac disease, and seizure disorders can result in intrauterine growth restriction, macrosomia, which is an extra large baby that we see with diabetic mothers, anemia, prematurity, immaturity, and stillbirth. And female genital mutilation and infibulation was discussed in a previous chapter. Human trafficking has become a serious issue. Screening patients for human trafficking is done in the primary care office. If you look at page 49, box 3.9, you will see some of the questions that you might ask to ascertain if this person is involved in human trafficking. IPV, intimate partner violence, is the most common form of violence experienced against women worldwide. During pregnancy, it's estimated that 300,000 pregnant women annually are affected by this. If she was abused before the pregnancy, the abuse may actually escalate during the pregnancy. Pregnant teens are abused more often than most adult women. Please see page 49, figure 3.9, for the cycle of violence, and we're going to discuss that on the next slide. Also read the legal tip box on page 50. The cycle of violence has 3 phases. Phase 1 is the tension building phase. Phase 2, the abusive incident. And phase 3, the honeymoon period, where he lovingly apologizes, brings her roses and candy, and swears it'll never happen again. This is a worldwide known symbol for the cycle of violence. And you can see that it just doesn't end. It goes around and around. And you need to, if you're involved in this cycle right now, find a way to make a plan to get out and break that cycle. Violence against women continued, battering during pregnancy. The rates range from 4 to 8% and may be as high as 20% in some populations. Incidents of intimate partner violence may escalate, like we said, during the pregnancy. It may happen for the first time when you become pregnant. Risk to the fetus includes increased rates of miscarriage, preterm birth, and stillbirth. This is your abuse assessment screening tool, and you can get a better look at that in your chapter on page 51. Spiritual approaches to women's health. Many women find that spirituality helps them remain healthy. Spirituality refers to the essence of our being and humanity, reflected in a connection to a sacred source. Nurses taking the holistic approach to nursing care must be sensitive and non-judgmental to the spiritual aspect of their patients. When you interview a patient for the first time, there are some communication techniques that you will find definitions for that are listed here on page 50 and 51 for your reading pleasure. I'm sure you're familiar with some of these already, and you will become more familiar with them in community health and probably in the rest of your classes. Here's a woman taking a history, very relaxed, talking to her patient. And the history consists of all of these things on this list here. You can see on page 52, box 3.10, for the history taking and assessment review that you should do at the first prenatal visit. Physical examination. First, we're concerned with their general appearance. When we first meet our patients, no matter whether they're prenatal patients or just any patient, there are some observations that we include in their first meeting, like the general appearance. Are they clean, well kept? Is their hair done, the nails done, or do they look homeless and smell of cigarettes? Are they black, white, Asian, Hispanic? Are they alert and oriented? Can they communicate well? As nurses, we know that the normal, healthy adult should look somewhat well kept. And if you look in their eyes, you should not see yellow, bloodshot sclera. It should be white and clear. Is their hair shiny or healthy and dull or dirty? That may be the sign of a vitamin deficiency. Nurses must use observation skills to pick up on abnormal things with our patients that need to be reported to the physician. Vital signs should be taken so that you can report this to the physician, because if you call them or you give them a chart, the first thing they're going to ask you is, what is your patient's vital signs? See pages 52 and 53 for a head-to-toe assessment findings guide. It's very detailed and very good. You might want to look at that. Cultural considerations and communication variations. Always be respectful of the culture of your patient. If you trust that the woman is the expert in her life, her culture, and her experiences, you will gain respect and genuine openness from her, and she will tell you whatever you need to know to take care of her. It may be considered inappropriate for a woman to disrobe completely for a physical examination. That may be part of her culture, just like some cultures will not permit a male to do an examination on the female. Women with special needs. We need to communicate with our patients openly and honestly and let them tell you about what is bothering them. Many hearing impaired women can read lips, write things down, or they do both. Orient the visually impaired patient to the room and explain everything to her before you do any procedures. Adolescents may or may not have a parent with them, so you have to gain their trust. Once you build a rapport with them, you can discuss things like sexual activity, eating disorders, and safety. This slide depicts different positions we may have to resort to put a patient in to do a pelvic examination. Some disabled or obese patients may not be able to get into the recumbent lithotomy position for a speculum exam or pelvic exam. The pelvic examination starts with an external inspection and palpation. The practitioner will inspect the inner thighs and all of the vulvar area. The vaginal wall will be inspected when the speculum is being withdrawn, and the physician will be looking at the sides of the vaginal wall for color change, lesions, rug, fistulas, and any bulging out portions of the vaginal wall. Collection of specimens will be taken during a vaginal examination for a pap smear, for different STDs perhaps. And the next things we talk about are listed on separate slides. This is your external examination, usually done first, followed by the speculum examination, and then the bimanual examination is done to check for masses and size and position of the female internal reproductive organs, and you can see this on page 58. This is your rectovaginal examination. It's done to assess the rectovaginal septum, the posterior surface of the uterus, and the region beyond the cervix and adnexa. Laboratory and diagnostic procedures that might be ordered are on the next slide, and most of these results can be reported to the person by phone or by letter. And this is a list of things that the doctor may deem necessary to do. Once they've seen the patient, they need further assessment for something, they may order some of these tests. Tests for HIV and hepatitis B and drug screenings may be offered with informed consent in high-risk populations. These tests are usually reported in person to the patient. Your question for this chapter says the nurse suspects that a patient who comes to the maternity clinic for a pregnancy test is in an abusive relationship. The nurse includes the abuse assessment screen as part of her assessment. Although the woman was very emotional and hesitant in responding to the questions, verbally she denies abuse as being a problem. While waiting for the results of the pregnancy test, the nurse decides to teach the patient about partner abuse anyway. The rationale for the nurse's decision is that all women should be informed about A, the nurse's ethical responsibility to protect patients, B, the cycle of violence, which continues and escalates over time once it begins, C, women's legal right not to be controlled by men, and D, the masochistic nature of women who stay in abusive relationships. Let's see, I'll give you a couple seconds to pick the right answer, and that would be B, correct. Because battery is followed by a period of calm and remorse, denial is a coping mechanism often used by battered women. During pregnancy, the nurse should assess for abuse at each prenatal visit and on admission to labor. This concludes our presentation.